Okay, let's unpack this. Today, we're taking a deep dive into something, well, incredibly vital to our daily lives. The intricate world of ear health and also the often underestimated significance of our lymphatic system. You've provided us with a fantastic stack of sources, videos, notes, the whole lot, and our mission, is to pull out the really important nuggets of knowledge, help you get informed quickly and thoroughly. We're talking everything from like common earaches to surprising causes of dizziness and even some crucial red flags our bodies might send.
Exactly. And what's truly fascinating here is just how interconnected these systems are. Understanding seemingly small details can actually give you profound insights into your overall health. We'll show you how to differentiate between common conditions and, maybe more importantly, really empower you to recognize when to pay attention to your body's signals and, seek further help.
Let's start right where many of us have probably had some experience. Ear infections. It kind of feels like a catch-all term sometimes, but from the sources, it's clearly not just one type, is it? What should we as listeners really understand about telling them apart? For proper care, I mean.
That's a really great point. It's vital to differentiate.
Here.
So the most common one is probably otitis media. That's your classic middle ear infection.
Okay.
Think of it happening right behind the eardrum, the tympanic membrane. It's typically caused by bacteria, often something called Streptococcus pneumonia.
Right.
And it presents with that classic ear pain, maybe a fever, sometimes muffled hearing. If a doctor looks, they'll see that eardrum is, bulging and red.
And the treatment.
Usually the first-line treatment is an antibiotic like amoxicillin.
Mm.
Pretty standard stuff for that one.
So that's the active bacterial infection. Got it. But what if someone feels that fullness, maybe some hearing loss, but doesn't have the intense pain or fever, suggesting it's not like a full-blown infection?
Ah, yeah. You're likely describing otitis media with effusion. Basically, there's fluid in the middle ear, but without those acute signs of infection.
Okay, so just fluid.
Exactly. It's
Yeah.
pretty common after a cold or even after an infection clears up. Often, it actually resolves on its own.
Oh, good.
Patients usually describe, like you said, fullness, pressure, some hearing loss.
Mm.
If it sticks around, though, especially in kids, an ENT specialist might need to get involved to check it out and potentially drain the fluid. You don't want it affecting hearing long term.
Makes sense. Then there's that really painful one, often linked with summer swimming, swimmer's ear.
Yes, otitis externa. That's an infection of the external ear canal, so everything outside the eardrum.
Right.
It's frequently caused by different bacteria, often Pseudomonas. And boy, it can be incredibly painful, especially if you touch or pull on the earlobe.
Oh, yeah.
There might even be some discharge, sometimes kind of foul smelling.
Yeah.
The ear canal itself looks swollen and very red on exam.
And treatment for that? Drops.
Usually, yeah. Topical antibiotic ear drops like ciprofloxacin. Sometimes they'll add a steroid drop too. Helps with the pain and swelling.
And I imagine there's a critical detail here, especially with putting drops in the ear.
Absolutely crucial. You nailed it. If there's any chance the eardrum is ruptured, maybe from a past infection or an injury, you have got to be careful with the type of drops.
Why is that?
Because certain drops are what we call ototoxic, meaning they can be toxic, damaging to the delicate structures of the inner ear if they get through.
Oh, wow.
Things like aminoglycosides, that includes common ones like neomycin or gentamicin, should definitely be avoided in that case.
So what's the alternative?
You'd use a non-ototoxic antibiotic drug, something like afloxacin.
Yeah.
They're much safer if they happen to reach the middle ear space.
That's a really, really important distinction, especially since, people might just grab over-the-counter drops. So the key takeaway for you listening isn't just knowing the names, but really understanding these subtle differences. They dictate safe and effective treatment. Okay, we've covered the more common complaints, but sometimes a persistent ear issue isn't just an annoyance, it's your body waving a serious red flag. And this next condition, cholesteatoma, really drives that home.
A cholesteatoma is definitely a major red flag. It's an abnormal, non-cancerous growth, but it's made of skin cells that form in the middle ear, right behind the eardrum.
Skin cells behind the eardrum.
Yeah, it sounds strange, but that's what it is. And it's not just a harmless lump. It can cause significant hearing loss and often a persistent, foul-smelling discharge. When a doctor looks, they might see a sort of retraction pocket or even a white cauliflower-like mass back there.
Okay.
Now, here's where it gets really remarkable and concerning. This growth isn't passive. It can actually erode the surrounding bone in the middle ear.
Erode the bone.
Yes. And even more critically, the facial nerve, that's cranial nerve 7, runs right through that area.
Oh, I see where this is going.
Yeah. A growing cholesteatoma can press on or even damage that nerve, potentially leading to facial paralysis on that side. It's a severe complication.
Wow.
So if a cholesteatoma is even suspected, it requires an immediate referral to an ENT specialist. Surgery is needed to remove it.
That truly emphasizes how ear health isn't just about hearing. It's about protecting vital structures, crucial nerves. Definitely a case where immediate action is critical.
Okay, shifting gears slightly, hearing loss itself. It can show up in different ways, right? And knowing the type of hearing loss seems key for treatment. How do doctors figure out if it's a problem with, say, the outer ear versus something deeper?
Right. That's where a couple of fundamental tests come in handy. Generally, we categorize hearing loss into two main types. First, there's conductive hearing loss. That's when sound waves just can't reach the inner ear efficiently. Could be something simple, like earwax blocking the canal.
Sure, happens to everyone. Or middle ear infections, like the otitis media we talked about, or even a perforated eardrum, basically a mechanical blockage. Then there's sensorineural hearing loss. This is more about damage to the inner ear itself, the cochlea or the auditory nerve pathway to the brain.
And what causes that?
Common causes include aging presbycusis, prolonged exposure to loud noise, or certain medications that can be ototoxic, damaging the inner ear structures.
Okay, two main types, and thankfully there are specific, pretty simple tests to help pinpoint the problem, right?
Exactly. The Rinne test is a classic. It primarily helps identify conductive hearing loss. It's quite clever, actually.
How does it work?
Strike a tuning fork. First, place the vibrating base on the mastoid process, that bony bump behind the ear. That tests bone conduction.
Right, through the skull?
Then immediately you move the still vibrating fork so the tines are near the ear canal opening. That's air conduction.
Oh.
Normally, you should hear the sound louder and for about twice as long through air conduction compared to bone conduction. We say AC is greater than BC. That's a normal or positive Rinne.
And if it's not normal?
Well, if you have conductive hearing loss, something blocking sound getting through the ear canal or middle ear, the bone conduction will actually seem louder or last longer than the air conduction. So BC greater than AC. That's an abnormal or negative Rinne test.
Huh. Any tricks to remember that?
Yeah. A little mnemonic some people use is a Rinne under the pinna for the bone placement. And just remember, air comes before bone alphabetically, and air conduction should normally be better or longer.
Got it. What about the other test?
Then there's the Weber test. This one helps differentiate the type of hearing loss, especially useful if hearing is worse in one ear.
Okay, how's that done?
You place a struck tuning fork right on the center of the forehead.
Okay.
If hearing is normal, or the loss is equal in both ears, you'll hear the sound right in the middle, or equally in both ears. No lateralization, we call it.
But what if it does lateralize?
Okay, this is where it gets interesting. If you have conductive hearing loss in one ear, the sound will actually seem louder in that affected or bad ear.
Louder in the bad ear. That seems backwards.
It does, but think about it. The blockage in the bad ear stops ambient room noise from interfering, so the bone-conducted sound from the tuning fork becomes much more prominent on that side.
Ah, I see. Clever. And sensorineural.
If it's sensorineural hearing loss, the sound will lateralize to the unaffected or good ear, because the damaged inner ear or nerve in the bad ear simply can't process the sound signals as effectively.
It's really amazing how these, seemingly simple tests with just a tuning fork can reveal such precise information about hearing, even pinpointing where the problem might be. That's powerful stuff.
It really is. Basic but very effective clinical tools.
Beyond hearing, the inner ear is also ground zero for balance. And that sensation of the room-spinning vertigo, it can be incredibly disorienting. What are some of the main inner ear issues that cause that feeling?
Yeah, vertigo is rough. One of the most common causes, especially for brief position-triggered episodes, is benign paroxysmal positional vertigo, or BPPV.
BPPV.
This happens when tiny calcium crystals, sometimes called ear rocks or otoconia, which are normally sitting in one part of your inner ear, get dislodged.
Dislodge.
Yeah, they break loose and migrate into the semicircular canals, the fluid-filled tubes that sense head motion. This disrupts the normal fluid dynamics and sends confusing signals about balance to your brain.
Ah, so loose crystals messing things up.
Pretty much. It's typically triggered by specific head movements, looking up quickly, rolling over in bed, that kind of thing. Causes a sudden, brief spinning sensation.
How do you diagnose that one?
There's a specific test called the Dix-Hallpike maneuver. A clinician carefully guides your head into a certain position while you're lying back quickly. If this triggers the vertigo and causes nystagmus, that's the involuntary jerky eye movement you see with dizziness, It's considered a positive test for BPPV.
Okay. And treatment.
And here's the really fascinating and incredibly practical part.
Hmm.
BPPV is often treated very effectively with something called the Epley maneuver.
The Epley, I think I've heard of that.
You might have. It's a specific series of precisely guided head and body movements. The goal is to use gravity to guide those loose crystals out of the semicircular canal and back into the chamber where they belong.
Like a physical therapy for your inner ear rocks.
Exactly. That's a great way to put it. And it can often provide immediate, sometimes really dramatic, relief from the vertigo.
Wow, that's incredible. A mechanical problem with a mechanical fix. But what about conditions that are maybe more chronic, broader symptoms, not just triggered by position changes?
Right. For a more chronic picture, you might be thinking of Meniere's disease. This is believed to be caused by an abnormal buildup of fluid and pressure within the inner ear endolymphatic hydrops technically.
Fluid buildup, okay.
The classic presentation involves a sort of triad of symptoms, meaning patients typically experience all three, usually in recurrent episodes.
What are the three?
Recurrent, often severe, episodes of vertigo, sometimes lasting hours. Tinnitus, which is that ringing or buzzing sound in the ear. And fluctuating hearing loss, often starting with lower frequencies, usually just in one ear. There's often a feeling of pressure or fullness in that ear, too. Nystagmus is also common during the vertigo attacks.
That sounds really debilitating.
It can be. And a major concern with Meniere's disease, beyond the disruptive episodes, is the potential for permanent progressive hearing loss over time in the affected ear.
So, a really key distinction there. BPPV is more like loose parts needing repositioning, often with a quick fix. Meniere's is a deeper fluid balance issue with potentially more serious long-term consequences for hearing.
That's a very good summary, yes. Different mechanisms, different management strategies, different long-term outlooks.
So much of what we've discussed today really relies on tuning into those subtle body signals. But sometimes the signals come from a different system altogether. One that often flies under the radar, our lymphatic system, specifically swollen lymph nodes or lymphadenopathy. When should they be a cause for concern for us?
That's an incredibly important pivot. Lymph nodes, these small bean-shaped glands you have scattered around like in your neck, armpits, groin.
Yeah, you can sometimes feel them.
Exactly. They act like little checkpoints or filters for your immune system. They trap viruses, bacteria, other harmful stuff. So it's actually very common for them to swell up when you have a simple infection like a sore throat, a cold, even a small skin infection nearby.
Okay, so swelling isn't always bad.
Not at all. It often just means your immune system is doing its job. They can also swell due to autoimmune conditions. But more seriously, they can enlarge because of malignancies, like cancers.
Okay, so that's the key. How does a doctor tell the difference between a normal reactive node and something worrisome?
That's the crucial nugget of knowledge for you, the listener. Generally, lymph nodes that are a bit tender, soft, and mobile, meaning you can sort of move them around under your skin, maybe feeling like a small, squishy pea, usually just indicate a benign response to infection.
Right, like with a cold.
Exactly. However, the red flags we look for, the ones that raise concern, are lymph nodes that feel hard, fixed, meaning they feel stuck down, you can't easily move them, and importantly, are non-tender.
Hard, fixed, and not painful.
Correct. Think of them feeling more like a marble or a small, hard pebble that seems anchored under the skin. That lack of tenderness can sometimes be more worrying than a tender node.
Okay, that's a key difference.
And these particular characteristics, hard, fixed, non-tender, become especially concerning when they're accompanied by systemic symptoms. We call them B symptoms sometimes.
B symptoms.
Yeah, things like unexplained fever, drenching night sweats like soaking your sheets, and significant unexplained weight loss. When you see those hard, fixed nodes plus these systemic symptoms, it raises a much higher suspicion for serious conditions like lymphoma or other cancers.
So what does this all boil down to for you listening? Recognizing these specific features, the feel of the node, whether it moves, whether it's tender, and paying attention to those associated symptoms like fever, night sweats, weight loss, it's absolutely crucial.
It really is. It's about becoming attuned to what your body might be telling you. Because catching serious conditions like lymphoma early, that can make an immense difference in treatment options and overall outcomes.
What a journey today into the real nuances of our ears and those, often hidden signals from our lymph system. We've covered a lot from telling apart common ear infections and their treatments right through to the serious implications of something like a cholesteatoma.
Yeah, and if we connect this to the bigger picture, it's really about equipping you, the listener, with knowledge to understand your body better. We explored how those seemingly simple tests, Rinne and Weber, can pinpoint different types of hearing loss,
Right.
and how something like the Epley maneuver can offer that immediate, almost miraculous relief for BPPV.
Yeah, the crystal thing.
Exactly. Contrasted with the more chronic, serious concerns around Meniere's disease and potential hearing loss.
And maybe most crucially, we really shone a light on how to recognize those critical red flags with lymph nodes, the hard, fixed, non-tender ones, especially when they come with fever, night sweats, and weight loss. Those are signals that absolutely demand attention.
Definitely. Knowing that distinction can be incredibly important, which I think raises an important question for you to consider. In a world just flooded with information, how do you become your own best health advocate? How do you learn to discern when something truly warrants a deeper investigation
Mm.
versus just being a common everyday complaint? Think about how being informed about these specific details, the feel of a lymph node, the pattern of dizziness, the difference between air and bone conduction, empowers you to ask better, more precise questions when you talk to your doctor, to truly understand the signals your body is sending. The more you know, really, the more effectively you can navigate your own health journey and make sure you're pursuing the right care at the right time.
Keep that curiosity alive, keep listening to your body, and we'll see you next time on The Deep Dive.